Thank you very much for the invitation. I think when Patricia first asked me to give this talk, I thought it would be an easy talk, and I have no disclosures. And I did, the typical PubMed search and Google search for what's been written about this topic, and there wasn't much. So what I thought I would do is talk you from my perspective. So first of all, I often hear about problems at the M&M conference. I think the residents, some of my residents in the audience, they know when I hear about a bad complication, it's always interesting to know, did you call somebody to help you? And also we have to protect the medical legal interests of the institution. And I've been a chair for 18 years now, so I probably have a perspective of what I expect our residents to do, what I expect our junior faculty to do when they have cases. So I've divided into 4 different things you should consider, and probably most importantly is the pre-op preparation. You know you're going to have a tough case. What do you think about the case beforehand? You know, when you're awake the night before, going through the steps in your mind, thinking about, can I do the best for the patient? Sometimes with intraoperative decisions, we really don't need anyone technically because you know you can do the operation, but should you do X or should you do Y? And there are some times when having another set of experienced hands will make the operation go much better and much safer. And lastly, about how to manage postoperative complications. So preoperative preparation, the first question is really, should you be doing the case? That's something, especially when you're early on in your career and you think that you can do everything. But I think it's worthwhile asking yourself, should I do this case or should I get help? You know, fortunately, I've had the, I guess, misfortune of being in an institution that had tremendous specialists in everything. And there are a lot of people in my institution that do the operations much, much better than I do. So why would I do an esophagectomy? Why would I do a thyroidectomy? So sometimes you may get referred cases where you probably aren't the best to do the operation. It doesn't mean you have to refer them out. Sometimes you can have someone to help you, but I just think you should ask yourself, for the interest of the patient, should I be doing that operation? Probably what is most appropriate, though, if you have a hard case that you know you're capable of doing, you've been trained to do it, is to call somebody and talk about the case beforehand, either someone in your institution or that you trained with. And some of the most pleasant calls I get are somebody who I had a part of a hand in training when they call me for my advice about a case. And I still look up for hard cases, an atlas, or I think now for in the laparoscopic area, look at some videos which may give you some tips. And I would just endorse the SAGE's TV website, which has essentially on every case you can imagine laparoscopically, they have experts who are giving you their pearls on how to get through those cases. So what I'm going to do is just give you some examples from my own career of where I've had tough cases and how I manage that. So the first one was I just finished residency, and I wrote this paper I guess in '95 on choledochal cysts in the adult, and I basically I'd done 3 or 4 of them, but we reviewed USC's experience. I wrote this paper, and one of the residents who had finished around this time called me, 4 or 5 years after he had finished training, and said he was in a community hospital in Camarillo, California, and he had a choledochal cyst, and he asked me, should I send that patient to you? And I knew he's an excellent surgeon. And I sort of know this operation pretty well. And I could tell, no, Kurt, you can do that operation. There are a few things you have to know. And one of the tips was getting it off the portal vein or dissecting out the hepatic artery. But I think your mentors or the people who help train you they enjoy giving you advice. And I would say it's okay to call him. He did the case, and the patient did just fine. The second is time you may need to get some advice is when you come up against something that is new in the middle of an operation. An example would be you're doing a sigmoid resection. You look up and you find a small met in the liver. What should you do? And sometimes you just may get a phone call. So I'm sitting in my office, and they don't usually call me for technical advice. They ask me, I see this. What do you think I should do? what's probably most gratifying, some of our most senior surgeons at our institution will call another colleague and say, can you come look? And I think that's a good principle to take with you for life. It's never a problem to call for help. Some of the decisions, it may be, for pancreatic stuff, should I resect, should I abandon, should you do a primary anastomosis or divert, do a duodenal injury for a trauma patient. Common duct injury is something which we all are fearful of ever happening, but if you're worried about it, do you think I have an injury? A phone call for someone to come in and look can be very, very helpful. Intraoperative bleeding and then the difficult gallbladder. I think we should congratulate Mike Brunt for his safe cholecystectomy initiative. And sometimes when I hear about a bile duct injury at our M&M conference, one of the first questions I ask, well, did you ask somebody to come help? I give the boards, the oral boards, a couple times a year. And when we get to a question about a different gallbladder, the old answer used to be, well, did you convert to an open cholecystectomy? Most of the junior attendings have not done that many open cholecystectomies. And them doing an open cholecystectomy, it may be not the best thing for the patient. And perhaps what we should ask them to do is to ask for someone to come help them in the course of laparoscopic dissection or to put a tube in or partial cholecystectomy. And I think it's something that we've had 2 bile duct injuries in my institution in the last 3 or 4 years by junior faculty. They both occurred after converting to open cholecystectomy. And again, Mike Brunt's 6 principles, critical view of safety, take a stop and take a time out during laparoscopic cholecystectomy to make sure you've seen the relevant anatomy. Always be nervous that something could be aberrant. If you need to, use cholangiography. And when you get around the zone of risk, just slow down and also call for help when you need it. In the open era, it was always, if you needed technical assistance, the first thing you did, your professor would come in and make a bigger incision. And I think that's actually interesting because sometimes it's either how to mobilize something or how to put laps in to get better exposure. But ask yourself in a laparoscopic case, would an additional port allow you to get better retraction to see things better? If it's very hard where you're dissecting, start from the known, going back to the unknown, and getting an experienced assistant. It's sort of fun, when you're a chief resident, you get to operate with 2 chief residents together. It's as opposed to struggling with someone who does know what they're doing, having somebody good to help you makes the operation go a lot easier. So here's my first big case when I was in practice. So I'd been in practice about a year. And I was on call. I got called with a patient who had a perforated giant 5-centimeter duodenal ulcer after getting chemoembolization into his gastroduodenal artery. And I thought myself, I was a pretty experienced surgeon. This was before there was cimetidine. I'd done dozens of perforated ulcers. This is going to be no problem. I got there, and I'd never seen anything this bad in my life. What should I do? So actually, I called, one of my mentors, Howard Silverman, who was actually the guy who interviewed me for residency, and he ended up suggesting we do a pyloric exclusion, which we did, and the patient did fine. And after I said to Dr. Silverman, I said, Howard, I was really embarrassed to have to call you. And he told me I'd be disappointed if you wouldn't have called. And I think your faculty and your senior partners will always appreciate the fact that you think they could provide assistance. Here's a case from about 4 or 5 years ago. It's going to be a great case, easy case. Villus adenoma with a stent place. It was going to be an easy Whipple. I was going to be done in 4 hours, I figured. What I didn't recall, if you look here, he's got calcifications in his aorta. He was 52 at the time. He had his first coronary artery bypass at age 45. I didn't appreciate how bad his atherosclerosis was. So we're doing the Whipple. My training was to clamp the GDA before you do the resection. So I clamped it, and it was actually the hepatic artery. So I didn't cut it. I didn't do anything. I just clamped it, and I moved on. And then I watched the hepatic artery thrombose in front of my eyes. I could just see it happening. I called vascular immediately, and they explained to me, well, there was calcification. I called it intimal dissection. They'd resected it. And then I did finish the Whipple. It thrombosed again by the time I finished. They came in a second time, put in a saphenous vein graft, and then post-op day 1, his enzymes were up to 1,000. His bilirubin hadn't ligated the duct, but got a CT scan, and you can see his left lobe was thrombosed, and here his vein graft has also thrombosed. What should I do? It's post-op day 1. So I called one of my best friends is a person named Will Chapman from WashU, who's a transplant surgeon, a lot of experience. So I called Will. He said, what do I do? He said, well, you got to take the patient back. You got to take the patient back right now. But Will said, but Keith Lillimode knows more than I do about this. You should give Keith the call. And I didn't know Keith that well. I mean, so I call him now. It's 4 o'clock, on a Friday, and I call him in his office. He's not in his office. The secretary says, well, I'll find him for you. And within about 15 minutes, he calls back. And he says, I've had this happen to me. You can wait it out. It's going to be really, really hard, but the patient will do okay. So let me back up. Eventually, it's strictured. We went through stents, balloon dilatation, left it in, took it out. But eventually it's strictured. You can see on this picture, the left duct does fill, but there's the stricture, pretty high up. What do I do now? So it turns out this patient's wife was the secretary to a very highly ranked person in the New York State government who was a physician. And he starts calling about, well, you had this complication. What are you going to do? And I thought I could fix it, but this is, at this level, he gets one shot at it. Probably the individual ducts, the third duct will be the left duct. He gets one shot at the repair. So I called another friend, John Emond at Columbia, who's a pediatric liver transplanter. And I explained it to him, and he was wonderful. He took the patient transplant, took the patient and did a primary anastomosis. And now when he has his episodes of cholangitis, he calls John rather than calling me. Now, this last case just happened last week, and this probably brings it all to conclusion. So I hired a very, very well-trained surgical oncologist, trained at Roswell Park. I'm sitting in at 6 o'clock at night. She says she wants to run a case by me. So I called her right back, and then I called Lisa, one of our residents, and got the name, looked at the films, and said, well, let's go look at the films tomorrow. And so this is a left lobe liver lesion. I guess I'm kind of old school. I still like going to look at pathology slides with the pathologist. And something I'd never seen. It was a spindle cell tumor, 22-year-old, which I thought was either going to be an adenoma. And then we went through all the differential diagnosis, which is relatively small, and decided we should do a resection. And I said, good luck. And she said, well, will you come help me tomorrow? Sure, I'll come help you. And we did a left lateral segmentectomy on the patient, did well. And then the next day she says, thank you for your help. Just made to pack you, took her gallbladder out. Thank you for including me. I said, great case. She looks great. So I think that case brings it all, and she did, I think, exceptionally. She was early in her practice, had a difficult case. She asked for help. I wasn't expecting to go ask her to help her or assist her, but she asked me to assist her, and I think it was a wonderful experience for both of us. So I think in summary, the things you should take note of are preoperative preparation, call for help to your mentors just for advice. If there's an intraoperative decision, the phone's always your friend. If you need technical advice, get it. And also you can call for help for postoperative management. Thank you very much.